Welcome back. In this episode, we're going to be discussing a paper that looks at preventing falls in adults with visual impairment. I'm Mika Moy, and our guest expert for this episode is Dr. Sherry Day, who is a clinical assistant professor of ophthalmology at the University of Michigan and low vision section leader there, and is on the Academy Foundation Board. Welcome, Sherry.
Thanks, Mika, for having me.
So today we're going to talk about an article called Understanding Falls and Its Prevention Among Adults with Visual Impairment Through Behavior Change Models by Sakadanandam and Narayana, which was published in the Academy's journal Optometry and Vision Science. So, Sherry, we know that visual impairment increases the risk of falls, but I didn't know that older people with reduced acuity were 1.7 times more likely to fall and almost 2 times more likely to have recurrent falls. So, what was this paper trying to accomplish?
Well, yeah, falls is such a prevalent thing, especially for older adults too. But the purpose of the paper was to understand the patient's perspective of falls, and then from that, propose strategies to prevent the falls in the future with behavioral change models. And I believe they had a range of 18 to 86-year-olds in this study with 36 participants. And the average age was 49. That's a wide range, of course, 18 to 86. And 28 of them were male of the 36. It's important to note that I think that they also had comprehensive eye exams, I believe, and tested for some devices. And they noted that the patients with visual impairment have some modified gait, reduction in postural stability, reduce visual attention, and of course, reduce ability to identify hazards.
So, what exactly did they find in this study?
Well, they found that there was a lack of knowledge about the significance of falls, and that they didn't really think it was a big deal, so they didn't really tell people whenever they fell. But then if they were injured, they wouldn't go to work, they wouldn't tell people. So now they became isolated. They're kind of became burdens on their family, which they didn't know either. And then I think the interesting thing, and which I see a lot of in my practice, is that patients are really focused on more the clinical treatment. They're always coming to me, I just want a pair of glasses, and just, I'm waiting for the treatment, or somebody's going to give me an injection to get better. And they're not accepting the permanency of their vision loss and the eye condition, preventing them from going to training to get the orientation mobility training that they need, or using low vision devices overall.
So that leads us, let's talk a little bit more about mobility training. So I'm interested to know if your personal experience is the same as what they were looking at in the study. So can you kind of summarize for us, what do we know about mobility training from the study?
These subjects were aware of the mobility training and the importance, but very few had undergone these trainings for a variety of reasons. And one of the major ones that I also see is lack of not access, but patients who have vision impairment, a lot of them in the US can't drive. So that's a huge part of our independence. So they were relying on their family or friends to drive them to places to get trained or get the devices, come to our low vision exam, for example, our appointments. Mm-hmm. And so that's a huge barrier for a lot of our patients to even get healthcare. And then, of course, there's still a stigma of showing and showing the public that you have vision impairment. I think in certain cultures, there's more of that than others. And I think this paper highlights that in India. And because they're holding a cane, for example, people go, oh, you can't see. Well, I'm just going to rob you, or, I'm going to bump into you, or, I'm going to do all these things. And they're just afraid of being out there with a cane and letting people know that they have this disability. So they feel like they're going to be targeted if they have a white cane.
That's interesting. And I think it brings up a good point. So this study was conducted in India. And maybe what I'm hearing you say is maybe they may have different concerns than, for example, low vision patients in the United States, or even in an urban area compared to a rural area.
Yeah, when you're in an urban area, of course, you have public transportation. For example, I'm in Ann Arbor, and so we have door-to-door service for anybody with any sort of disability, whether it's physical, vision, whatnot. But in the urban area, so I have patients who drive hours to come to see me, and they just land everywhere. So they don't have public transportation to get from their house to even the grocery store.
Mm.
We can easily say, oh, why don't you move to town? Well, it's not easy for them to pick up and leave. And that's where their center is, their family is, right? And so, but what's interesting in the US that we have, privilege that we have, is that if you are legally blind, we can connect them with Bureau Services for blind persons. And they have counselors that are stationed around the state that can come to your home, come to your neighborhood, maybe work with you in your grocery store to navigate that.
Oh, wow. That's fantastic. So, what are some takeaways from this paper?
Well, the authors ended up recommending what they call a SMART or SMART strategy to prevent falls. S stands for support from caregivers and assistive devices. And most of the families are willing to do that, but it's taken time to do that. So the patient might not ask for that. M is for monitoring of the falls. It could be self-monitoring to prevent falls. What could cause you to do that? To reduce self-isolation at home, and so that you don't fear going outdoors. A is awareness about falls. So this has a lot to do with again, accepting your condition, getting some of the counseling if you have access to that, and education campaign about falls to the patient, family, and the community. And then R is for reducing home environmental hazards. That's pretty logical. Removing obstacles. So in the home, most patients are pretty safe. They know everything, where everything are. But if somebody comes into their home and starts moving things around, or their spouse or family does it, then they're really in trouble. And T for training skills. And so learning orientation mobility. And we discussed the lack of access issues, and where the U.S. has that privilege.
Yeah. So that seems to kind of a nice way of remembering things, especially for those of us who don't practice low vision like me. But if I want to have a patient that I want to counsel, or my own family, are there any other things you want to comment on about this paper?
There's actually a couple things I wanted to comment on. So the paper highlights many comorbidities that come along with vision impairment. That's very worth noting. And unfortunately, the paper did not. That wasn't their focus, and they didn't have time to do that. But they did talk about emotional distress. And I mentioned the social stigma. And in the U.S., we can't drive. Now they've lost your independence, self-isolation, safety concerns. And this is such a huge issue that I've seen in my 26 years of practice, that we now have an NIH grant where we are incorporating emotion regulation therapy with our psychology or psychiatry department. And so we're just beginning that study. Financial burden is another one that's well documented in some of the papers out there. Because as we mentioned, you could lose your job if you fall, or you have vision impairment. You can't change, or you have to change jobs. For example, truck drivers, if they have any vision impairment, well, they can't drive. So what are they going to do next? Increase in healthcare costs, lack of acceptance and use of devices. And some people prefer to just apply for disability, unfortunately. And then this is a public health concern, right? As we mentioned, we need more education of just vision impairment, how to enable and help these people to do their jobs, to take care of the families, and prevent falls so they can continue to be independent. Um, and I think that the paper was pretty well done. I just had some questions about the paper, and some things to highlight. That paper, the patient's recall bias. So we're asking the patients to remember. So when you have an 86-year-old recalling versus 18-year-old, it's a little different. Um, and then the patients were only recruited from one center in India,
Mhm.
right? And I don't know if it's rural or not, but I think it would be good to have a diversity of community and support backgrounds, and kind of randomize that. It also assumes visual acuity as the fall factor, I believe. I don't think they mention anything else, but there is in our study, we've seen contrast sensitivity to be one of the biggest issues
Mhm.
to falls, because when you have poor vision, you can see the stairs, but if you have poor contrast, you cannot see that set of stairs, right?
Yep.
The stairs is a big target. But if it's all gray, all cement, there's no, yellow paint or anything, you'll miss those stairs. And type of vision loss, they didn't talk about central, peripheral, or perhaps scotomas with diabetic retinopathy. So that you perceive a little differently depending on your vision loss. And of course, I mentioned the wide range of age, right? Older folks in general are just more unstable than the 18-year-old.
Mm.
Like, I'm more unstable than the 18-year-old, my kids.
Oh, me too. Well, Sherry, thank you so much for joining us today to talk about this article with us, and we hope to see you next time.
Thank you for having me.